doing this presentation. So I'm going to go ahead and share my screen. Can you all see my screen clearly? Yes?
Yes.
Okay. Awesome, thank you. So I'll go ahead and get started with my talk today. So my presentation is titled Coagulation, Cascade and Bleeding Disorders. So I'm going to start with the basics of coagulation cascade. It is extremely important for you to understand the coagulation cascade clearly in order to evaluate a patient with a bleeding disorder. So once you memorize the coagulation cascade, then any puzzle in concern with coagulation abnormalities becomes very easy. I want this presentation to be completely interactive. So feel free to pause me in between and ask questions. I will also be having some case scenarios in between and I'll ask questions, and I hope some of the audience can answer those questions. Don't feel intimidated at all. These questions are not to intimidate you. It is only to stimulate your thinking. It is okay to give a wrong answer because we are all here to learn. So the overview of my talk is as follows. First, I'm going to talk about hemostasis. So we'll look at what is primary, secondary, and tertiary hemostasis. Then we'll get a detailed look at coagulation cascade. I'm going to take my time to go through this. I'll probably repeat it a couple of times. And if you can, please repeat the coagulation cascade with me the second time at least. And then we'll look at the coagulation tests, prothrombin time, partial thromboplastin time, fibrinogen and D-dimer, and see how we can apply these tests when we evaluate a patient with bleeding disorder. Then we'll have an overview of inherited and acquired coagulation disorders. And as I said, I will have interesting case scenarios throughout, so you can connect the basics to the practical aspects of managing a patient with bleeding. So let's start with primary hemostasis. Whenever someone gets injured, there is bleeding. So when there is excessive bleeding, obviously if there's blood loss, that is not good. So the bleeding has to be stopped. So that is the natural physiologic mechanism in a way that the body responds. So how does that happen? As soon as there is an injury to the tissue, the platelets get activated and they migrate to the area of injury and agglutinate to form what is called the platelet plug. So this is the first plug that stops the bleeding, that controls the bleeding. However, this is not very firm. So left alone, this can easily get dislodged and the bleeding can resume again. But in the meantime, there is activation of the coagulation factors in a cascade-like manner, meaning one factor gets activated that goes on to activate the next one. So just like how you would see in a cascade. So that is why it is called the coagulation cascade. And the end product of that is activated fibrinogen, otherwise called fibrin, which forms a very firm fibrin clot. And this is very effective in stopping the bleeding. So this is secondary hemostasis where the coagulation factors get activated. Eventually, once the bleeding is stopped in a blood vessel, the blood flow needs to be reestablished. So the clot starts to contract and starts to undergo fibrinolysis. That is your tertiary hemostasis. Now, let's take a look at the coagulation cascade. This is a very simplified version of the coagulation cascade. Of course, there are much more complex versions of this. I'm going to start with only the simplified version. If you can understand this clearly, I think that's extremely important. This coagulation cascade consists of an extrinsic pathway, an intrinsic pathway, and a common pathway. So in the extrinsic pathway, whenever there is tissue injury, tissue factor is produced. That along with activates factor 7, and so then activated factor 7 along with calcium and phospholipids leads into the common pathway to activate factor 10. So what do you have in the extrinsic pathway? The most important factor is factor 7. So when there is tissue injury, tissue factor is produced, activates factor 7, that leads to the common pathway to activate factor 10. What about the intrinsic pathway? When there is tissue injury, there are some substances that are produced that causes activation of a set of factors called the contact factors. These include factor 12, prekallikrein, and high molecular weight kininogen. So these are the first set of factors, the contact factors that get activated in the intrinsic pathway. They go on to activate 3 very important clotting factors in a cascade-like fashion. What are they? Factor 11, factor 9, and factor 8. So these 3 are extremely important and I'll tell you shortly why. And once these are activated, then that again leads to the common pathway to activate factor 10. So in the intrinsic pathway, when there is bleeding, tissue injury, there is a production of substances that activate the contact factors 12, prekallikrein, and high molecular weight kininogen that go on to activate factor 11, which activates factor 9, and then that in the presence of activated factor 8 leads into the common pathway. What do we have in the common pathway? Factor 10 is the first factor which gets activated to form factor 10A, and that goes on in the presence of activated 5 to activate factor 2, otherwise called prothrombin. So prothrombin then gets activated to thrombin. Thrombin converts fibrinogen to fibrin monomer. These are single strands. And then when you have multiple monomers, they combine to form a polymer, fibrin polymer. But even this fibrin polymer is a little bit loose. And so this has to be cross-linked to form a very, very firm link and an established fibrin clot. And that cross-link happens in the presence of activated factor 13. So what are the factors in common pathway? You start with factor 10, which gets activated by both the extrinsic and the intrinsic pathway. And the activated factor 10 goes on to activate factor 2, otherwise called prothrombin, in the presence of activated 5. And prothrombin gets converted to thrombin, which converts fibrinogen to fibrin. Fibrin monomers are formed first, then polymers are formed. That gets cross-linked to form the cross-linked fibrin polymer or the established fibrin clot. And for the cross-link, you need the activated factor 13. So I hope this is clear. This is extremely important. If you have any doubts here, please let me know. So clinically, how do we apply the coagulation cascade? The prothrombin time, which is a coagulation screening test, measures the extrinsic pathway and the common pathway. Whereas the partial thromboplastin time measures the intrinsic pathway and the common pathway. Okay? So when the common pathway factors are affected from all the way from factor 10, 5, factor 2 or prothrombin fibrinogen, both PT and PTT will be prolonged. Whereas if it is only factor 7 that is deficient, that will prolong only your prothrombin time. Likewise, if there is deficiency of factor 8, 9, 11, or the contact factors in the intrinsic pathway, there is isolated prolongation of PTT. So if you can remember this, then you can solve any puzzle. Can anyone tell me which one will be prolonged? Will PT or PTT or both be prolonged if there is factor 13 deficiency?
Both of it.
You think both will be prolonged?
Isn't that the common pathway? So
I have circled the common pathway within this red circle here. So does factor 13 lie within the common pathway or outside?
Outside of it, ma'am.
So will PT and PTT be affected?
No.
No. So that's very important to remember. A patient who presents with bleeding, you're doing PT and PTT, both are normal. Then you think of factor 13 deficiency. Is that clear? Okay. So can everyone mute, please, so we don't get any disturbance in the background? Okay. So that is the coagulation cascade in a nutshell. And let's move on to the fibrinolytic pathway. Once the fibrin clot is formed, I told you, eventually fibrinolysis begins. So the lysis is brought upon by plasmin, which is activated from plasminogen by tissue plasminogen activator. TPA is also commercially available and used for thrombolysis. TPA is inhibited by PI1, plasminogen activator inhibitor 1. plasmin is inhibited by alpha-2 antiplasmin. So deficiency of pi1 or alpha-2 antiplasmin also can cause rare bleeding disorders. So fibrin gets broken down eventually to form fibrin degradation products. Another measure of that is called D-dimer. And so both fibrin degradation products and D-dimer can be elevated when there is exaggerated fibrinolysis or when there is ongoing clot formation, because you're getting more fibrin clot and that gets broken down, and so D-dimer can be elevated in those situations also. So let's take a look at what is prothrombin time. I told you prothrombin time measures the extrinsic and the common pathway. So it is actually the time that takes the plasma to clot when it is exposed to tissue factor after injury to the tissue, and it assesses both the extrinsic and the common pathway. So time that it takes for the tissue factor and activated factor 7 to initiate the extrinsic pathway all the way up to the fibrin clot formation. That's your prothrombin time. The normal range is usually 11 to 14 seconds. But typically coagulation tests are affected by the reagents used in the lab, by the strength of the reagents, by the instruments that are used in the lab. So there can always be lab to lab variation. But for prothrombin time, we have what is called the INR, or the International Normalized Ratio. Using this formula, this ratio actually standardizes the prothrombin time. So if you get an INR in one lab, you can very well compare that to the INR obtained in another lab. Okay? This is something that we have for prothrombin time. We do not have that for the partial thromboplastin time. So what are the uses of prothrombin time? Coagulation screening tests are typically used when you evaluate a patient who is presenting with clinically significant bleeding. So when you see a patient with bleeding, the first thing you need to think about is to do a complete blood count, because that gives you the hemoglobin and hematocrit. That gives you an idea about how much the patient has bled. And also it gives you the platelet count, and that is also another, you remember primary hemostasis is by platelet plug formation. So if your platelets are low in number, then you're going to bleed because of that also. So complete blood count is the first test that you're going to get. And then you have to get coagulation screening tests, namely PT, PTT, and fibrinogen. So PT is very important to evaluate a patient who presents with clinically significant bleeding. Also, another condition called disseminated intravascular coagulation, where there is both ongoing bleeding and thrombosis. So when there is clot formation, there is consumption of coagulation factor. This is also called consumptive coagulopathy. And then a patient is not bleeding, but the patient is going for a major surgery, and you're worried, will the patient bleed during surgery? So how do you find out? Before the patient goes for surgery, you need to check their coagulation screening tests to make sure their baseline coagulation system is normal. So that's very important. Otherwise, undetected bleeding disorders can manifest perioperatively. Patient can bleed significantly. So that needs to be avoided. And then also before you start a patient on anticoagulants, because anticoagulants are going to put the patient at risk for bleeding anyways. And if the patient's coagulation system is already affected, the bleeding is going to be more. So it's extremely important before a patient goes for surgery or you start on anticoagulants to check the PT, PTT, and fibrinogen, make sure that coagulation system is normal. If it is abnormal, it needs to be corrected before you take them up for surgery or start them on anticoagulants. And then it is also used for assessment of liver synthetic function. Clotting factors are synthesized in the liver. So if the liver synthetic function is affected, then your clotting factors will be deficient. Another substance, protein that you think about will be albumin and prealbumin. But along with that, checking the coagulation screening test also can give you an idea about the liver synthetic function in patients who have liver dysfunction. And also vitamin K deficiency. So vitamin K is produced by the intestinal flora, and that then gets absorbed and in the liver. So for absorption, this is a fat soluble vitamin. So presence of bile becomes important for its absorption. And then in the liver, it activates some enzymes for formation of certain factors, which are factor 2, 7, 9, and 10. So these are your vitamin K dependent clotting factors. And so vitamin K deficiency can lead to deficiency of these factors that can then prolong your PT or PTT. So another important point here, of all the clotting factors, the factor with the shortest half-life is factor 7. So that is, it has a half-life of about 4 to 6 hours. So when there is early vitamin K deficiency, the first factor to be affected is factor 7. So when factor 7 alone is low, all the other clotting factors are normal, which test will be affected, PT or PTT? Now you have to remember your coagulation cascade. Can anyone tell me?
The
PT.
PT, ma'am.
PT, very good. So that's an extremely important point clinically, okay? When there is only isolated prolongation of PT, you think of vitamin K deficiency and also liver synthetic function, because factor 7 has the shortest half-life of 4 to 6 hours. It is also used for monitoring anticoagulant warfarin therapy. So let's see, if a patient presents with prolonged PT, what are all the possibilities? So I have the coagulation cascade here, just in case you need to refresh your memory. So we talked about vitamin K deficiency and liver disease. In both instances, early stages, PT alone will be prolonged. But when this is more established and other clotting factors become deficient, then you have both PT and PTT prolongation. Also, DIC, this is a situation where there is both bleeding and thrombosis. So consumption of multiple clotting factors, both PT and PTT will be prolonged here. You also have some inherited factor deficiencies. Factor 7, a patient can be born with factor 7 deficiency. It's rare, but it can be seen. And so that also can prolong your PT. And also there are some combined factor deficiencies where both PT and PTT will be prolonged. We talked about monitoring warfarin therapy. So when a patient is on warfarin, your PT and INR will be prolonged. Typically for warfarin therapy, we set the INR goal to be 2 to 3. 1 is normal. So INR of 2 to 3 is where we set to maintain that INR when a patient is on warfarin therapy. And then other anticoagulants can also prolong, but typically PT is not used to monitor these therapies. In addition to factors, so these are all situations where there is factor deficiency. But in addition to factor deficiency, when there is no factor deficiency, but when there is an antibody to the factor that impairs its function, right? And these are called antiphospholipid antibodies, also called lupus anticoagulants, which can also prolong the PT. This is a very rare situation with PT. Usually these antibodies prolong PTT, but rarely we have seen this happen for PT also. And specifically when there is antibody to prothrombin or factor 2, which can cause a condition called hypoprothrombinemia. So let's move on to PTT. So PTT is partial thromboplastin time. But the test that we use currently is activated partial thromboplastin time. So when I say PTT, I'm going to use PTT and APTT interchangeably here. So I'm actually meaning APTT. So APTT measures the time it takes for the plasma to clot, starting from your intrinsic pathway, from when the contact factors get activated, all the way up to formation of the fibrin clot. So this is what the PTT measures. And the normal range is usually about 25 to 35 seconds. Here again, PTT can be affected by the reagent used in the lab, by the instrument used in the lab. And so unfortunately, the PTT range can vary from lab to lab. For a given patient, you do the PTT in one lab, and in another lab, the values can be different and they are not comparable. So that's important to remember. So what you need to compare it to is the normal range established in the lab. So that's what you can compare it to. So say, for example, I go and get a PTT done in one lab. I may have a value of 34, which is in the normal range for that lab. But in another lab, it may be 37. But you have to look at the normal range for that lab. And if that normal range for that lab goes up to 40, my value is still normal. It's not abnormal. So that's important to remember. It varies from lab to lab. So what are the uses of PTT? Just like what we talked about for PT, it is again used for evaluation of patient with unexplained bleeding, for diagnosing disseminated intravascular coagulation, to evaluate a patient prior to surgery or prior to starting anticoagulation. And for therapy, we use this for monitoring patients on unfractionated heparin. Also, it is useful to monitor some other anticoagulants like the direct thrombin inhibitors or argatroban or bivalirudin. So when you see a patient with prolonged PTT, what are the possibilities? Here again, liver disease and vitamin K deficiency status, you can see prolonged PTT. So I mentioned that only in early stages, PT alone is prolonged, but subsequently all clotting factors are affected. So in established liver disease and vitamin K deficiency, you will see PTT prolongation also. Likewise in DIC, because there is consumption of multiple clotting factors. When it comes to inherited factor deficiencies, with factor 8 deficiency or factor 9 deficiency, which are called hemophilia A or B, you can see prolongation of PTT. Also, any of the other rare factor deficiencies can cause prolongation of PTT. Contact factors. So that's an important point about contact factors. Contact factors, if they are low, they will prolong the PTT. But interestingly, they don't cause clinical bleeding. So when a patient presents with bleeding and there is isolated prolongation of PTT, the three most important clotting factors you need to think about are factor 8, 9, and 11. So even if you're woken up in the middle of the night and you're told that there's a patient with bleeding, only PTT is prolonged, what do I need to think about? It should be a knee-jerk response, factor 8, 9, 11. These factors need to be assessed immediately to make a diagnosis and to treat the patient. If these are normal, then you may think about these, but this is not going to really help you clinically. There's also a bleeding disorder, a very common bleeding disorder called von Willebrand disease, where factor 8 levels can be low, and we're going to look into what is von Willebrand disease when I'll explain this more. So that can prolong the PTT. Other situations will be when a patient is on heparin and the direct thrombin inhibitors, and also DOACs and fondaparinux. We talked about 5-factor inhibitors. There can be specific inhibitors to factor 8 and factor 9 that can prolong your PTT, or general inhibitors like lupus anticoagulant. So this is something that we see very commonly, especially in children when they have infections like viral infections, transient viral infections. This can prolong your PTT. But what is important to remember here is the patient does not have a risk for bleeding, because this does not neutralize the factor. And so usually we get these case referrals, say a child is going for tonsillectomy, the ENT physician wanted to assess the coagulation system, they did PT and PTT before the surgery, PTT is prolonged. Oh my God, does this patient have a bleeding risk? What should we do? So if you evaluate further and if you find that the lupus anticoagulant is positive, and making sure that the relevant coagulation factors are normal, you can reassure the surgeon, this is just because of lupus anticoagulant, there is no factor deficiency, there is no bleeding risk, the patient can be taken for surgery. So this is a very typical case scenario that we see often. Another thing that you need to remember is, whenever you take the blood sample for doing PT or PTT, it's extremely important to take sufficient blood to fill up to the mark in the test tube. Why? Because there is an anticoagulant solution that is very proportionate to the blood sample that should be taken. If that ratio is affected for some reason, that will affect your test results. So if you get only blood to fill half of the tube, that's completely invalid. It is not even worth doing the test. It has to be discarded. You have to take a fresh blood sample that will fill the tube completely. So that's very important. Likewise, when a patient has polycythemia, when the hematocrit is high, that will affect the ratio of the blood to the citrated anticoagulant solution in the test tube. You can have false prolongation of PTT. So something to remember. Let's move on to fibrinogen. Fibrinogen is a precursor to fibrin. We saw that in the coagulation cascade, and either low levels of fibrinogen. The normal levels are usually about 200, 220 to 400 or so. either low levels of fibrinogen or an abnormal fibrinogen protein, what is called a dysfunctional fibrinogen, can cause bleeding. And this can be seen again in DIC when there is consumption, liver disease because that's where it is synthesized, or there are also inherited or acquired disorders of fibrinogen where this can be seen. Fibrin D dimer, I showed that the fibrin degradation products or the D dimer are the end product of fibrinolysis. So once the fibrin clot is broken down by plasmin, then you get formation of these products. D dimer consists of two D domains that is cross-linked by the activated factor 13. This is more clinically applicable and best studied and validated. So this is a better test for clinical use rather than FTP. I think in my medical college days, we have used FTP, but currently D dimer is widely used. And depending on what units you use, the normal range can vary. So make sure you compare it to the appropriate normal range. Clinical uses here, I told you that D dimer is a measure of fibrinolysis. So when there is ongoing clot formation and more fibrin degradation, then you'll see this. So when D dimer is elevated, that can indicate ongoing clot formation like deep vein thrombosis or pulmonary embolism. So in adults presenting to the emergency room with chest pain, shortness of breath, D dimer can be done as a screening test, and if elevated, then you can move forward to do other imaging studies to rule out pulmonary embolism. So it has a clinical application there. And also in DIC, the D dimer is going to be elevated, and it also indicates exaggerated fibrinolysis or hyperfibrinolysis. Say for example, you're in a place where you cannot get specific coagulation factor assays. You're evaluating a patient for bleeding and PT and or PTT is prolonged. So how do you know if this is because of factor deficiency, or there is no factor deficiency, this is just an inhibitor like a lupus anticoagulant, I don't have to worry about treating this patient? How do you distinguish between the two? So that is when you can do what is called a prolonged PT-PTT workup, by which I mean where you will be doing a 1:1 mixing study with normal plasma. So you take the patient's plasma and mix it with equal amounts of normal plasma. So in this situation, say the patient actually has a factor deficiency, and that's why there is prolongation. When you mix it with normal plasma, what happens to the factor deficiency? Now, by normal plasma, I mean the patient, somebody with plasma containing normal amount of clotting factors. So when you mix a plasma containing a good amount of coagulation factors, will the low levels get corrected in the patient's plasma, right?
Yes, ma'am.
Yeah, so that will get corrected. So when there is factor deficiency, when you do the mixing study, the PT-PTT prolongation will normalize. Whereas when there is inhibitor, even if you add normal plasma, the inhibitor is still present. It doesn't go away. So it's going to do its work. And so the prolongation persists. So that tells you about prolongation, that tells you that there is an inhibitor. So a clinical situation, patient is having some bleeding, you're not sure if you need to treat it or not, then you do the mixing study gets corrected, then you know there is factor deficiency, and you know that you can treat this patient with either a specific factor if available or even a fresh frozen plasma. Okay, let's move on. So here is a nice algorithm that will help you to figure out the differential diagnosis for different case scenarios. So in a patient presenting with bleeding, you do PT, PTT, and if the PT or PTT are abnormal, you find out whether it is only PT prolongation. If it's only PT, then I told you factor 7. That's the most important factor to think of. Other situations will be early vitamin K, liver disease, or rodenticide poisoning, because that's a derivative of coumadin. Also, whether the patient is on warfarin. So these are your possibilities if there's only PT prolongation. PTT alone is prolonged. Patient has bleeding. Told you the 3 most important factors, factor 8, 9, and 11. So those are the things that you need to think about. Also contact factors, common scenario with lupus anticoagulant when the patient has an infection. And then heparin, presence of heparin can prolong the PTT, and another bleeding disorder called von Willebrand disease. When both are prolonged, you think of DIC, sepsis, liver disease, vitamin K deficiency, etc. When neither PT or PTT are prolonged, so both PT and PTT are completely normal, but the patient has bleeding. What is the factor deficiency? You can look at the table and tell me.
13, ma'am.
13, ma'am.
Very good. Okay. All right. Okay, let's move on to looking at inherited coagulation disorders. I'm going to briefly talk about hemophilia A and B, and then hemophilia C, von Willebrand disease, rare coagulation factor deficiencies, and fibrinolytic pathway defects. So I'm going to present the first case scenario here. A 3-day-old male infant presents to the emergency room with complaints of continuous oozing from circumcision. Again, this is a frequent case scenario that we see in the clinical situation. On examination, the patient is looking very pale. You're getting a complete blood count. The hemoglobin is low. It's 9 grams. So that tells you how much the patient has bled. So this can happen from circumcision, from just a venipuncture, like you want to draw blood and you've done a heel stick. The patient can ooze to the point of losing a lot of blood. White blood count and platelet count are normal. What studies will you obtain next?
PTT and prothrombin time and APTT.
Very good. So whenever we say PT-PTT, invariably you have to think about getting the fibrinogen also, because I told you there can be fibrinogen disorders also. So that's another lab test that you can avail. So we typically order PT, PTT and fibrinogen. Okay. So let's say this patient's PT and fibrinogen are normal, but PTT is prolonged. I told you the normal range is about 25 to 35 seconds. This patient's PTT is 85 seconds. So clearly prolonged. Right? And I have your coagulation cascade here. This patient is presenting with bleeding, right? So what are the factors that you need to think about?
8, 9, 11.
Excellent. That's what I wanted to hear. Factors 8, 9, and 11. And we typically recommend ordering these assays stat, because if you can do these test assays, then quickly you'll find out what factor is deficient and you can give the exact factor product, and that will help to stop the bleeding. Very good. Okay, so that takes us to hemophilia A and B. These are inherited bleeding disorders. And hemophilia A is because of factor 8 deficiency. B is because of factor 9 deficiency. The inheritance is X-linked recessive. As a result, females are carriers. Why? Because females have 2 X. If they have one abnormal X, they also have one normal X. So the normal X to some extent protects them. So that minimizes their disease severity. And so they are only usually carriers. Whereas males have only one X that is affected, and so they manifest the disease completely. So boys are affected with hemophilia A or B. So usually there's a family history, but up to 30% can be a new mutation. So you may not get a family history then. Okay. So interestingly, these two factors, the factor level correlates very well with the bleeding severity and the clinical phenotype. So when there is less than 1%, that's termed severe hemophilia. 1 to 5% is moderate, 5 to 40% is mild. As a rule of thumb, factor levels are normal, the normal range being 50 to 150%. And so anything lower than that, you have to think of a factor deficiency. So severe hemophilia patients, what's very important is that they can have bleeding spontaneously. And so these patients can bleed into their joints. Blood in the joint is very destructive. It destroys the joint cartilage and it makes them crippled. So in established hemarthrosis, these patients cannot even walk. They are wheelchair bound. They may have to go for joint replacement. Whereas mild and moderate hemophilia, usually the bleeding is after trauma or surgery. Spontaneous bleeding is rare. So let's take a look at what are the types of bleeding that we see with hemophilia. You can see bleeding with circumcision, as seen in our case scenario. Intracranial hemorrhage. It can happen at the time of birth, especially. It's reported in about 1 to 2% of the neonates. Here's a CT scan of a neonate with hemophilia with intracranial bleed. You can see how much of the cerebral cortex is getting destroyed. This has devastating neurological consequences and should be absolutely prevented. Okay. And I told you that in patients with severe hemophilia, bleeding into the joints, major joints, especially knee joint, ankle, elbow, hip joint, these are the joints that are typically affected. And then you can have intramuscular bleeding, soft tissue bleeding, hematuria, bleeding after surgery or trauma, easy bruising. Their legs and arms will be filled with bruises. And mucosal bleeding is also very common after tooth extraction. Also in an infant, as the teeth erupt, if they have some injury, then that can tear the mucous membranes, and torn frenulum is a very common case scenario that we see. Here is an X-ray of a patient with hemophilic arthropathy, and you can see here that the joint is extremely thinned out. It's almost both the bones are touching each other. And this is very, very damaging to the joint and can be very painful. And over time, this leads to adjacent bone thinning, osteoporosis, and fibrotic changes. And so it becomes a very crippling arthropathy. Very important to prevent this in the current age. And it really hurts me to see a patient with an established hemarthrosis in a hemophilia patient when there are ways to prevent this. How do we manage these patients? This can be classified as on-demand therapy or factor prophylactic therapy. On-demand therapy is a patient is presenting with bleeding and you're going to treat the bleeding. So how do we do that? We can do that by replacing the factor. We have a variety of factor choices. I'm not sure what factors are currently available in India, but any factor product, factor 8 product or factor 9 product for hemophilia A or B can be given. Previously we used to have short acting, but we now also have long acting factors that last in the blood system for a much longer time. So you have your choices there. In developing countries, you don't have access to factor. You are in a remote village, you don't have factor. You know the patient has hemophilia. How do you treat? You can give fresh frozen plasma. Fresh frozen plasma, rule of thumb, 1 ml per kilogram of fresh frozen plasma will elevate your factor level, any factor level, by 1%. So that's how usually we treat. We usually give about 15 to 20 ml per kilo. That will increase the factor level to 15 to 20%. You're not going to go correct it completely to normal, but you'll convert the patient to a mild hemophilia state. And that is good enough to stop any major bleeding. Also, cryoprecipitate can be given. The disadvantage with these is that these are derived from human beings. So there is a high risk for transmission of viral infections. So whenever you have specific clotting factors, that's what you have to resort to. Of course, there is a research ongoing for gene therapy. And also now we have the availability of another medication called emicizumab for hemophilia A, which is a non-factor therapy. And then supportive measures like rest and ice application are important. Antifibrinolytic agents like epsilon aminocaproic acid and tranexamic acid can be used for mucosal bleeding. When there is blood in the urine, hematuria, in addition to giving factor, you have to hydrate the patient and give bed rest. Here, antifibrinolytics should not be used because if they clot, then that can cause urinary tract obstruction. And then in patients, especially with severe hemophilia, invariably, all patients with severe hemophilia go on what is called factor prophylaxis. What do I mean by that? These patients should get factor replacement on a regular basis, depending on the factor you use. 2 times a week infusion or 3 times a week infusion or once a week infusion should be given, and this prevents them from having a joint bleed. So this is a picture that walks you through how hemophilia therapy has evolved. Prior to the 1950s, we were using whole blood. And then there was a bit more purification. So we used blood products like FFP and cryoprecipitate. And there was further purification. And then we had the plasma-derived factor. But all these have transmission of viral infections. This is the era when there was a lot of hepatitis, and also HIV emerged in the 1980s. And so that's when we started looking at more purification and went to recombinant techniques, and then had first generation, second generation, and third generation recombinant factor products. Many of these are short acting factors. And then with the 4th generation factor, now we have long acting factors. So for example, for hemophilia A with short acting factor, you have to give replacement thrice a week. That is IV infusion thrice a week, IV access. That's quite cumbersome. With a long acting factor, you can cut it down to twice a week for A, hemophilia A, and for hemophilia B, even once a week or once in 10 days is feasible. 2018, there was approval of this non-factor therapy called emicizumab. This is actually a bispecific antibody. If you remember your coagulation cascade, activated factor 9 leads to the common pathway, factor 10. So this antibody binds 9 directly to 10, and so completely bypasses 8. So you don't need 8 to induce clotting. So that's really a very important development, because the non-factor therapy can be given subcutaneously. So you don't have to go looking for a vein to inject the factor. So this has really brought about a dramatic improvement in the care of hemophilia patients. And of course, gene therapy trials are ongoing, very close to getting completed. Hopefully after COVID, we'll have gene therapy emerge for hemophilia that is using the AAV vectors. General principles here, the level of correction, how much factor you give, how long you give, how frequently you give, depends on the severity of the bleeding. For example, a patient who presents with intracranial bleed, you want 100% correction and you give it as frequently as you can, and you give it at least for 10 to 14 days. Whereas if it's a soft tissue bleed, you can maybe just give 1 or 2 doses and the bleeding should be controlled. And just quickly to some basics about factor dosing for 8 and 9. Factor 8, 1 unit per kilo increases the factor activity by 2%. So if you want 100% correction, you will give 50 units per kilo. And the half-life is 8 to 12 hours. So you have to dose every 8 hours or every 12 hours. Factor 9 infusion, 1 unit per kilo increases the factor activity by 1%. So if you want 100% correction, then you have to give 100 units per kilo. Half-life is 24 hours, so you can dose the patient less frequently. Hemophilia C is factor 11 deficiency. Here the inheritance is autosomal recessive. So both sexes, boys as well as girls, both will be affected. It's not a very severe bleeding disorder like hemophilia A or B. So joint bleeds are not something that we see here, but mucosal bleeding, menstrual bleeding, bleeding after surgery or trauma, you can see. And evaluation, if you remember your coagulation cascade, the isolated PTT prolongation is by 8, 9, and 11. So this deficiency will cause PTT prolongation, and then you can check factor 11 levels to confirm diagnosis. A specific factor 11 product is not available, and so if you have to treat the patient, you have to give fresh frozen plasma. And any of the other coagulation factors in the coagulation cascade also can be deficient. These are termed rare coagulation disorders. They are much less frequent when compared to the other clotting factor deficiencies, but that is also possible. Also, fibrinogen disorders, you can have severe deficiency, value of less than 5. When the patient has severe bleeding, congenital afibrinogenemia, extremely rare. I have seen a couple of patients with this. And you can have hypofibrinogenemia when the values are in the range of 50 or 100. This can also be acquired when there is liver disorder. Dysfibrinogenemia is something we frequently see. Interestingly, these patients may have an increased bleeding risk or an increased clotting risk or both. You can also have combinations. And then I talked about these rare bleeding disorders called fibrinolytic pathway defects, PI1 deficiency, and alpha-2 antiplasmin deficiency. So our next case scenario, 13-year-old female who presents to the emergency room with heavy menstrual bleeding for 10 days. CBC shows anemia. Her PT-PTT fibrinogen has been ordered. What else do you want to get? Any guesses? So here, this is an important condition called von Willebrand disease. And so you can request a von Willebrand panel to evaluate the patient presenting with menstrual bleeding. This is actually the most common inherited bleeding disorder, very commonly prevalent, but often goes undiagnosed. Why? Because menstrual bleeding is common in these patients, and families may think, oh, heavy menses runs in our family. I don't have to get a medical attention for this. Likewise, nosebleeds can also get ignored, and that can be caused by von Willebrand disease. And this is because of either deficiency or dysfunction of the plasma protein von Willebrand factor. Normal range is 50 to 200 and half-life is about 12 hours. It plays a role in both primary hemostasis and secondary hemostasis. So von Willebrand promotes platelet aggregation. So that is your primary hemostasis. Von Willebrand is also the carrier protein for factor 8. So when von Willebrand is not present, factor 8 quickly gets removed from the plasma. So factor 8 levels will go down, and because of that, it affects secondary hemostasis and can cause bleeding. Grossly, there are 3 types, type 1, type 2, and type 3. Type 1 is quantitative, mild deficiency. This is the most common type of von Willebrand disease you'll see. Type 2 is qualitative because the protein is abnormal. And type 3 is very severe. The levels are less than 5. This is also quantitative. Here the patient can have severe bleeding, just like hemophilia. They can even have joint bleeds. Clinical features typically with the milder type especially, mucosal bleeding, epistaxis or nosebleeds, heavy menstrual bleeding. These are extremely common. Bleeding after dental procedures, surgeries, trauma-induced bleeding, and easy bruising. How do you treat? You can treat them with what is called non-replacement therapy. The medicine called desmopressin promotes release of von Willebrand factor that is stored in your own endothelial cells. So you're not supplementing it externally. It causes the body to release what it has already. So that can be utilized, but when there is severe bleeding or you need prolonged replacement, then you can give von Willebrand factor. Von Willebrand factor is present in plasma-derived factor 8 concentrates. We use here what is called HUMATE-P. I don't know what is available in India. Or a pure recombinant factor also has more recently become available. But when you don't have that, you can use that. Here again, you can use cryoprecipitate. Cryoprecipitate contains a high concentration of von Willebrand, keeping in mind it has a high risk for transmission of viral infections. And supplemental therapy, mucosal bleeding, you can give antifibrinolytic agents, and hormonal therapy for menstrual bleeding. Contraceptives can be given. Let's go to take a look at acquired coagulopathy, vitamin K deficiency, liver disease, DIC, anticoagulant overdose, acquired inhibitors to clotting factors, rodenticide poisoning, and rarely amyloidosis where you can have acquired factor 10 deficiency. So these are some of the acquired coagulopathies. I'm going to just quickly touch upon some of the acquired coagulation disorders. Here's another case scenario. A newborn infant was delivered at home, breastfeeding, and she's referred to you because of some bleeding from the umbilical cord and blood and stool. What is the possibility here? She was delivered at home. That's your clue. Any guesses? She is otherwise well. She's looking well. So DIC patient will be very sick. So it's probably not that. Let's say you do a CBC, her platelet count is normal. So this is not thrombocytopenia. So this is a very classic scenario for vitamin K deficiency. What are all the scenarios where you get vitamin K? I told you vitamin K is produced by the intestinal flora. So any disease affecting the intestine with malabsorption, medications like antibiotics that affect the gut flora, and cystic fibrosis. And also I told you that bile is extremely important. So any biliary disorders can cause vitamin K deficiency. Also, liver is where vitamin K dependent coagulation factors are synthesized. So that is another situation where you can get vitamin K deficiency. This is called hemorrhagic disease of the newborn in the neonate, and it can be seen in breastfed infants because at birth they are somewhat vitamin K deficient, so we have to supplement vitamin K. So many countries have prophylaxis by giving IM vitamin K injections or oral vitamin K to newborn infants. For all newborn infants, it's important because this is a very easily preventable cause of bleeding. If these patients develop intracranial bleeding, again, it can be devastating. And so these patients can develop cutaneous bleeding, GI bleeding, or intracranial bleeding. We talked about the vitamin K dependent clotting factors and prolongation of PT first, followed by PTT. How do you manage? Vitamin K supplementation is important, but in a bleeding patient, you have to quickly produce, supplement the factors. So you have to give FFP, and prevention is by giving vitamin K at birth. Let me move on to the next case scenario. 10-year-old boy admitted because of sepsis and bleeding. He's very sick and he's bleeding. His platelet count is low at 50. PT is prolonged, PTT is prolonged, thrombin time is prolonged, D dimer is high. What does he have? And I told you that he has sepsis and he's bleeding, multiple PT, PTT prolonged, that tells you DIC. Very good. So this is a consumptive coagulopathy. It can be acute or subacute in presentation. This consumption of multiple coagulation factors. So you'll also have thrombocytopenia, prolongation of PT and PTT, low fibrinogen, and elevated D dimer. A variety of clinical situations can cause DIC. And this is the coagulation parameters that we talked about, right? PT, PTT, thrombin time are all prolonged, platelets is low, fibrinogen is low, clotting factors are low, and fibrin degradation products and D dimer are high because there is ongoing bleeding as well as ongoing clotting. How do you treat these patients? Most important is to treat the underlying cause. If the patient has sepsis, you treat that with antibiotics. So that once that gets controlled, DIC improves. But in the meantime, when the patient is bleeding, whatever factor is necessary, you can supplement that with either platelets, FFP, cryoprecipitate, and red cell transfusion if the patient is very anemic. Another case scenario here, 4-year-old male requires tonsillectomy, has throat infection, pre-op labs show PTT of 45, that's prolonged. Coagulation factors 8, 9, and 11 are normal. What could this be due to? I gave you the answer. So it could be due to any of these. Any of these are possible, but the most common scenario is lupus anticoagulant because this patient has a throat infection. So lupus anticoagulant is present usually transiently for 1 to 2 months. And that's when the PTT is prolonged. You test the patient after 2 months. When the patient doesn't have an infection, PTT will go back to normal. This is not a bleeding risk. That's very important to remember. This is not a bleeding risk. And so you can clearly tell the surgeon that this patient does not have a bleeding risk. Patient can go for surgery. So I think these I explained. Another scenario where we see lupus anticoagulant is in autoimmune disorders like systemic lupus erythematosus. It also can cause a condition called antiphospholipid antibody syndrome, which is actually a risk for clotting, and another rare condition called lupus anticoagulant hypoprothrombinema syndrome, where PT is prolonged. So that brings me to the end of my talk. Key points to remember. When a patient comes to you with bleeding, the test to order are CBC, complete blood count, PT, PTT, fibrinogen. When the patient has mucosal or menstrual bleeding, you also think of checking the von Willebrand panel. Very important to memorize and remember the coagulation cascade. If you remember the coagulation cascade, you can solve all puzzles with coagulation. And remember your inherited bleeding disorders and how to treat them. Remember vitamin K deficiency and disseminated intravascular coagulation and how to treat them. And know about lupus anticoagulants, a very common finding, and this is not a bleeding risk. Here are some resources that can be useful for you. And I'm happy to take questions. Any questions? So you're all ready to evaluate a patient with bleeding now. Is that correct? Any questions, feel free to ask me. You don't have to hesitate. It can be anything.
Maybe you can directly email Dr. Srivaths as well.
Yeah, feel free to email me. I can forward it to you and Dr. Prasad Mane, and maybe you can share it with all of them.
Yeah, I think you can share it in our group, Share and Learn group. You can just write down your email, man.
Absolutely, absolutely.
Yeah, in that case, you just mention your email, and I think the boys and girls, whoever is there here, they can pass it to their individual batches.
Okay, that's very good. Yeah.
That was an excellent talk. I think it's really, I think it's a long time ago you are reading this bleeding, and I think it's nice case scenarios, and I think it's very useful for these final years. Even I think it covers all the pediatric cases, all the pediatric bleeding disorders. And yeah, that's an excellent presentation. I think
thank you. The basics of coagulation are going to be the same whether you're treating a child or an adult. So that's extremely important. I think clinically it will be extremely useful. So very important to remember the basics of coagulation. That can be useful for anybody, a general physician or a specialist who wants to specialize in hematology. It'll still be very useful. So I hope everyone found it.
Yeah, and again that the hemophilia history was very good. So like the people knows now can say about almost 20 what's happening, and these things they can come across, and this even this single question can pass them. Some of the examiners will be really, they just want to ask one, and they may give distinction also. I think that medicine you mentioned, that's all really important. This makes really a big difference over the last 27 years ago. When we are the medical student, we have no clue. So we know up to whatever it's in the textbook. So these textbooks, what we are reading is for the 10 years old. If you see the index of the textbooks, it says 2010 research. Even whatever the new textbooks, I think it's really excellent. I think somebody raised some question from Dharmapuri. I think somebody from Dharmapuri is attended this Dharmapuri Medical College. Who was that? Who is that attended from Dharmapuri Medical College? There's something they written in the comments.
In the chat?
Yeah.
Okay. I'm not able to see that. If you want to read it, we can maybe, if they have a question, we can answer that.
Yeah.
I couldn't, I'm not so sure. I don't see anything on the chat though.
Okay. I think it may
no worries. So just making sure, I mean, I know in the past we didn't have specific factors for treating hemophilia, but I think they are available now. may not be readily available, but if you don't have that, then always think of FFP and cryoprecipitate. Very extensive talk. I'm doing mainly coagulation workup. Thank you very much. That's
Yeah,
from
I think the
Dr.
madam is there. I think we have to introduce the madam, our professor. She's
Oh, excellent.
Professor Febi. I think she's a
Nice.
senior most alumni. I think very interactive with the pathology sessions. She's leading the
Oh,
pathology sessions. Dr. Febi, I think, madam, you can say a few words, madam.
Yeah, thank you very much.
thank
It
you.
was yeah, nice. From the beginning, I've been listening from the beginning. So,
Thank you. Thank you.
yeah, I'm from 1976 batch.
Oh, excellent.
So, doing mainly hematology. So,
Okay.
we have started a workshop. Today also, we were doing that workshop.
Okay.
So, I thought they're really very good with case scenarios. Students would have been benefited a lot.
Thank you very much, madam. Thank you very much for saying. I know you will be doing all the coagulation tests and etc. in your lab, so you would
Yeah.
have, that part would have been
Ah.
very applicable to you. Yeah. Thank you so much. I think hearing that from you, really affirms the importance of this kind of a talk. Thank you for
But
that.
the problem is in Tamil Nadu, only few centers are doing.
Yeah.
Not many. And another thing is mainly the coagulation is with in government setup. It's with biochemistry,
Okay. Okay. I
not
see.
with pathology people.
I see. Okay.
In
Yeah.
the private setup, it's with pathologists.
Right. Okay. So I think it's very important for these tests to be available in the lab. So hopefully moving forward, it'll become more readily available. And also for the factors, at least some factors to be available, if not the most sophisticated or, the recombinant factors, at least some factors ought to be available. I know I have actually interacted with some people taking care of hemophilia patients there. And I know some factor availability is there. But I think it just needs to become more readily available everywhere.
Yes, it should be at least 8, 9 at least.
Yes, very true. Awesome. Thank you very much. Thank you, Maithili, for organizing, and Dr. Prasad Mane for organizing. I think there's a Dr. Pratap Neelakantan.
Hi, ma'am. I'm Pratap here. I'm one of the hematologists from UK. It's a very nice
awesome.
talk. I
Excellent.
really enjoyed listening. As you say, coagulation is the same for an adult or a kid. It doesn't matter. The basics are the same.
Yes,
that's a really nice talk.
Excellent. Thank you very much. Can I ask you where in UK you work?
I work in Reading and Oxford. So I mainly do adult. I don't do much pediatrics.
Excellent.
Yeah,
Thank you very much.
Pratap also is very active, and he's I think with the Febi madam, he is doing an excellent work. I think these guys are quietly doing and completely changing the KMC students the way approach to all these things. I think they really it's a good teachers and good students. We are all we're going to have a nice for next year.
Excellent.
Madam is doing such excellent work, and Pratap is really because we are getting so much of feedback about these guys' classes, and madam is coordinating such a nice way. And this is all about Dr. Maithili's initiation about doing this CMEs every 15 days. That's all credit goes to Dr. Maithili from 82 batch.
Come on, Dr. Prasad, please.
Please,
that's
Thank
totally.
you.
Thank you, Dr. Phoebe, and it was so nice to meet you. It's an honor to meet you. To see you.
Thank you so much.
We are so blessed to be amidst you.
With all that you're doing, you're really an inspiration, ma'am.
Thank you.
Yeah, thank you so much for being there for us. It's so nice to. I'm really truly blessed to bring this all together, and I wish we had the same kind of opportunity. I really wish that we had it.
Absolutely.
But then I'm so glad I'm able to at least participate in it and initiate this. And thank you, Dr. Phoebe, for being here for us.
Thank you so much. Thank you.
Thanks. Thank you all. I'm so happy that I was able to contribute in a small way. And just like, Dr. Prasad and Maithili said, when we did our medical college, everything was textbook knowledge. And practical application and how to connect it to the practicality was what was lacking. And I hope my talk attempted to sort of help with that.
Yeah. Thank you very much, Dr. Srivaths. Thank you, Dr. Phoebe. Thank you, Dr. Pratap. Thank you,
Thank you,
Dr.
all the
Prasad
students
Mane, for
who
getting this
coordinated.
coordinated, getting the
Thank
ball
you,
rolling.
students, and thank you, students who listened, and whoever is
yes.
technical team. I think these guys are
Yes.
working hardly to get all
Yes.
these things. We have to just to thank everyone.
Yes, I chime in on everything what Dr. Prasad said. Thank you, students, and thank you for the greatest technical assistance. Thank you.
Bye.
Thank you.
And see you all soon.
Bye-bye.
Adios.
Bye.